Welcome back to the deep dive. Today, we're tearing through some really dense material to get to what you actually need to know. We're talking clinical chemistry.
hmm
But this isn't about, just memorizing every normal range. This is about understanding the core systems, fluid, electrolytes, acid base that, well, can immediately threaten a patient's life when they fail.
Right. And that urgency is exactly what the authors, Hughes and Jefferson, hammered home in Clinical Chemistry Made Easy.
I remember that from the preface.
Yeah, they stress that this knowledge has to be immediately applicable, especially in those high-pressure, out-of-hours situations.
Yeah.
You can't just order a few tests and hope for the best.
No, you have to integrate it. Clinical skill plus a really rapid, systematic understanding of the labs.
That's our mission today.
Okay, so let's unpack this. We're going to start with the real foundations, the systems that go haywire first when a patient gets sick, fluid and electrolytes.
Then we'll hit the deadly dance of potassium.
After that, the blind spots in renal function, and finally we'll decode acid-base balance.
Sounds like a plan.
I want to start with what I think is the most common conceptual trap with fluid status. We tend to use the words sodium and water almost interchangeably, but the source material is crystal clear that the body controls them separately.
It is. And getting this right is fundamental. I mean, it completely defines your management strategy.
So what's the core distinction we need to burn into our brains right now?
You have to separate volume control from concentration control. They are not the same thing. Sodium balance, that controls the volume of the extracellular fluid, the ECF. Too much sodium, you get volume overload. Too little, volume depletion.
And water.
Water balance controls the serum sodium concentration. That's what gives you hyponatremia or hypernatremia. So think of it this way. Sodium tells you about the size of the tank, the volume.
Okay.
And water tells you about how concentrated the fluid is inside that tank.
That really crystallizes it.
Right.
And just to lay the groundwork for everyone, total body water is about 60% of body weight, right? 2/3 inside the cells, 1/3 outside.
Exactly. With sodium as the main ECF cation and potassium as the main ICF one, all held in place by that NADK ATPase pump.
Right.
Now, how the body controls volume is primarily through the kidneys managing sodium, and they're incredibly good at it. Of the, 25,000 millimoles filtered every day, less than 1% is usually excreted.
So when volume drops, say, from a hemorrhage, the body just clamps down.
It clamps down hard. Baroreceptors fire up the whole angiotensin-aldosterone system, and the kidneys retain sodium aggressively. Clinically, you'll see this as a urine sodium of less than 10. That's a huge sign of true volume depletion.
Okay, so that's volume. Water control, on the other hand, is all about thirst and antidiuretic hormone, or ADH. That's the aquaporin channel story, right?
It is. But here's the clinical nugget, the hierarchy of ADH release. Yes, high salt concentration, hyperosmolality is a huge trigger for ADH. But other things can override it.
Like what?
Decreased blood volume, pain, stress, nausea. All of these can crank up ADH release.
So, if volume is the body's #1 survival priority, what happens in a patient who's both volume depleted and has dilute blood, like from really bad gastroenteritis?
This is where people get tripped up. The rule is simple. Volume restoration takes absolute precedence over osmolality.
So the body will try to save blood pressure at all costs.
At all costs. If the patient is clinically dry, that stimulates ADH release even if their plasma is already dilute. The body will hang on to every drop of free water to maintain perfusion, even if it makes the hyponatremia worse. The immediate threat of shock is just. It's more important than the slower threat of plasma dilution.
That makes the whole topic of hyponatremia much clearer. So a low sodium, anything under 135, is basically just too much water relative to the amount of sodium.
And to get there, you need two things. First, a source of electrolyte-free water. That's easy, IV fluids or just drinking too much water.
And
Second, the kidneys have to be unable to excrete that water, which, as we just said, is usually because ADH is being stimulated by a volume problem.
Now, when it comes to treatment, the speed of correction is everything. It's not the number, it's the timeline.
Absolutely. You have to know. Is this acute, meaning less than 48 hours, or is it chronic? If it's acute, the brain hasn't adapted, and the risk is cerebral edema. You might need to be aggressive with, say, 3% saline.
But if it's chronic, the danger completely flips.
Yes, the danger becomes central pontine myelinolysis,
Yeah.
CPM. The brain adapts to chronic low sodium by getting rid of its own internal osmoles to stop itself from swelling.
So if you correct the blood sodium too fast.
Water rushes out of those adapted brain cells, causing osmotic demyelination. It's a disaster. That's why the target is so strict. less than 1 millimole per liter per hour, max of 10 to 12 over the first 24 hours. The pace is literally the difference between recovery and irreversible brain damage.
Okay, so if volume is priority one, potassium feels like it's under the tightest security. 98% of it is locked inside our cells.
Which makes that tiny amount in the plasma, normally 3.5 to 5.0,
Right.
incredibly sensitive to any shifts.
And that sensitivity translates directly to the heart.
Correctly. Even small shifts, hypokalemia below 3.0 or hyperkalemia above 6.0, these are life-threatening medical emergencies. They destabilize the myocardial cell membrane.
Let's take the low end first, hypokalemia. The symptoms are all about the cell membrane being hyperpolarized, less excitable, muscle weakness, fatigue.
Ileus, and the really scary one, ventilatory muscle failure. On the ECG, you're looking for those flattened T waves and prominent U waves.
And we have to think about what's causing it, especially shifts into cells.
Right, things like insulin, beta-2 agonists like a salbutamol nebulizer, or systemic alkalosis. And this leads to a critical management tip from the source material.
Which is
When you're giving IV potassium in an emergency, never, ever use dextrose solutions.
That seems odd. Why would dextrose make it worse?
Because dextrose stimulates insulin release. And what does insulin do? It drives potassium into the cells. So you're effectively pushing more potassium away from the plasma, making the hypokalemia worse, even while you're trying to replace it.
Ah, of course. So it has to be potassium chloride in normal saline.
Has to be. Something like 40 to 60 millimoles per liter.
That's a brilliant clinical pearl. Now, the flip side, hypokalemia, a cardiac time bomb. What are the ECG signs we need to watch for from earliest to latest?
First thing you'll see are tall peaked T waves. Then the PR interval gets longer, the QRS complex starts to widen, and finally you get the ominous sine wave pattern.
And when you see that, the patient is basically pre-arrest.
Absolutely. At that point, you have to follow the 3-step emergency protocol, no exceptions.
Okay, step one.
Step 1, stabilize the myocardium. Give IV calcium gluconate, 10%, 10 mils over 5 minutes. It doesn't lower the potassium, but it protects the heart from its effects. It buys you time.
It's a short-term shield. Okay, step two.
Step 2, shift the potassium to the cells. Now the insulin and dextrose combo is our friend. 6 units of fast-acting insulin with 50 mils of 50% dextrose. That pushes the potassium intracellularly fast.
And step three is getting it out of the body entirely.
Correct. You increase elimination, usually with a cation exchange resin like calcium resonium. Or, if the patient has renal failure or it's just not working, the only definitive option is dialysis.
Let's pivot to the kidneys. Serum creatinine is the test everyone orders, but it's famously a terrible marker of early problems.
It's a huge clinical blind spot. Creatinine doesn't usually rise into the abnormal range until you've already lost more than 50% of your renal function.
And it depends so much on muscle mass.
Exactly. You could have a frail 50-kilo woman with a creatinine of 100, and her GFR could be terrible. A 100-kilo bodybuilder with the same creatinine of 100 has perfectly normal function. The number itself is almost meaningless without context.
I fell into that trap early in my career. That muscle mass variable is so key. So for chronic disease, how do we track function better?
The book talks about a great tool, the reciprocal creatinine plot. You plot 1 over the plasma creatinine against time. Since 1 over creatinine is linearly related to GFR, you get a straight line showing the rate of deterioration. You can actually use the slope to predict when they'll need dialysis. It lets you plan ahead.
And that's why we now rely on estimated GFR, the eGFR formulas, which factor in age, sex, and weight.
Absolutely. The eGFR is critical for things like drug dosing, where the raw creatinine would be dangerously misleading.
Beyond the markers, we have to talk about drugs that interfere with the kidney's own protective systems. Renal autoregulation.
Right. The kidney is amazing. In low-flow states like dehydration, it keeps its filtration rate, the GFR, stable by dilating the incoming arteriole,
The efferent arteriole?
using prostaglandins, and constricting the outgoing, or efferent arteriole, using angiotensin II. This keeps the pressure inside the glomerulus just right.
But so many common drugs mess with that. What's the danger with ACE inhibitors and NSAIDs?
Let's take a scenario. A patient with heart failure is on an ACE inhibitor. Then they get gastroenteritis and become dehydrated. The ACE inhibitor is blocking that angiotensin II mediated constriction of the efferent arteriole.
Which is the very mechanism the kidney needs to maintain pressure when it's being hypoperfused.
Exactly. The pressure inside the glomerulus plummets, and you risk acute renal failure.
So the ACE inhibitor, which is good long-term, becomes a liability in an acute crisis.
Precisely. And NSAIDs do the opposite. They block the prostaglandin-mediated dilatation of the afferent arteriole. So the learning point is that both these drug classes strip the kidney of its ability to cope with low perfusion. It's a setup for disaster.
Okay, so all these systems fluid, electrolytes, renal, when they fail, they almost always lead to our final and most complex topic, acid-base balance. It all comes down to the Henderson-Hasselbalch equation. The pH is just a ratio of bicarb from the kidneys to PCO2 from the lungs.
And that ratio is everything. To figure it out without missing something, you have to be rigid. You have to use a step-by-step approach. The book lays out 7 steps.
Okay, walk us through them. Steps 1 to 4, what do we do?
1. Check the pH. Is it acidemia, so under 7.35, or alkalemia, over 7.45? 2. Check the bicarb for the metabolic part. 3. Check the PCO2 for the respiratory part.
Pretty straightforward so far.
Then, 4. Assess compensation. And their ironclad rule here is that compensation never overcorrects. The body's always trying to drag the pH back towards 7.40, not push it over into the opposite problem.
Why is that rule so important?
Because if the compensation is more or less than you'd expect, you know you have a mixed disorder. For example, in an acute respiratory acidosis, for every 10 the PCO2 goes up, the bicarb should go up by about 1. If it goes up by, say, 5, you know there's a metabolic alkalosis happening at the same time.
That brings us to the real powerhouse for metabolic problems, the anion gap.
Step 5, calculate the anion gap. Sodium minus chloride plus bicarb. Normal is around 12. This is the key fork in the road for metabolic acidosis.
Because it tells you if you've gained an unmeasured acid, which gives you a raised anion gap.
Or if you've just lost bicarbonate, which gets replaced by chloride, keeping the anion gap normal.
Okay, let's take the raised AG category first. Who are the usual suspects there? The unmeasured acids?
It's the classic muddy piles mnemonic. You've got lactic acidosis, ketoacidosis from diabetes or alcohol, renal failure with its retained sulfates, and certain poisons like methanol or ethylene glycol.
And what's this step 6, the delta-delta ratio?
You only use that for a raised anion gap acidosis. It helps spot a hidden second problem. If the change in the anion gap is way bigger than the change in bicarb, like a ratio over 1.5 to 1, it suggests you have a raised AG acidosis plus a simultaneous metabolic alkalosis that's hiding in the numbers.
And step 7 is just finding the cause.
Find and treat the underlying cause.
Now, what about the normal AG acidosis, the hyperchloremic type? We know we've lost bicarb. Where from?
2 main places. The gut diarrhea is the classic cause, or the kidneys, in a renal tubular acidosis, or RTA.
And there's a test to tell them apart.
Yes, the urine anion gap. You calculate sodium plus potassium minus chloride from a urine sample. In diarrhea, the kidneys work fine. They sense the acidosis and dump acid in the form of ammonium, which is an unmeasured quotation, so the UAG becomes negative.
But in RTA, the kidneys are the problem.
They can't excrete that ammonium effectively, so the UAG stays positive, or at least not negative enough. It points you directly to the faulty organ.
Regardless of the cause, what are the red line numbers? When do we get really worried about a metabolic acidosis?
When the pH drops below 7.2, or the bicarb is below 10, at that point you get seriously depressed myocardial contractility, enzymes stop working properly, vasopressors don't work. It's an extreme emergency.
We've covered a lot of ground today. The crucial difference between volume and water, the cardiac risk of potassium, the blind spots of creatinine, and that 7-step guide to acid base. And of course, in a real patient, these things are all happening at once.
They are, which is why that systematic approach is so vital. To really nail it down, maybe we should run through a quick case using that 7-step framework.
Great idea.
Okay, here's a review exercise for you. A 65-year-old patient has severe diarrhea. Their blood gas shows a pH of 7.28, bicarb of 18, PCO2 of 35, sodium 140, and chloride 108. So is this a simple or mixed disorder, and what's the anion gap?
Okay, let's run the steps. pH is 7.28, so that's an acidemia. Bicarb is 18, that's low. So the primary problem is a metabolic acidosis.
Good. Now for compensation.
Right. The bicarb dropped by 6 from a normal of 24 down to 18. So we expect the PCO2 to drop by about the same, roughly 6. Normal is 40, so we're expecting a PCO2 around 34.
And the actual is?
The actual is 35. That's almost exactly what we'd expect. So this is a simple metabolic acidosis with appropriate respiratory compensation.
Perfect. And the anion gap?
Anion gap is sodium minus, chloride plus bicarb. So 140 minus 108 plus 18. That's 140 minus 126, which gives an anion gap of 14.
And since normal is around 12, that is a
normal anion gap acidosis, which fits perfectly with losing bicarb from diarrhea.
See, that systematic application gets you the right diagnosis and narrows the cause almost instantly.
That really drives home the point. Thanks for breaking this all down. I think the final takeaway has to be what the authors said in the first place. You have to integrate this data. Don't just order the tests.
Right. It's never enough to just order a few tests. You have to
Hmm.
put it all together with what you're seeing at the bedside.